transplantation?
This is a retinal detachment case, removal of oil a month ago, but then when I went in, I realized that there was a macular hole creation. At the time that the PVR surgery, I had peeled the epiretinal membrane, I had peeled the ALM, I had nothing else to peel. So I decided to put a patch on the macular hole and started to create an autologous RPE retina implant patch, and I placed it over the macular hole. This is the patch that you saw. I thought that it was a little bit disintegrated during the oil-in, so I placed it in the proper position. Fortunately, 4 months later, the graft looks that has been nicely adapted to the area. Unfortunately, this patient created ciliary body atrophy and ended up with pressure 0.2, which leads to phthisis, I think.
What is the panel's experience with this full thickness retina in the macular hole? Any comments? Anybody has done that? Nobody?
Well,
go ahead.
I think that if it works just as a patch, but it shares nothing regarding the healing process. That's from my understanding. It just prevents the fluid going into the macular hole. Like if you have a good gas bubble, it will do the same job. But I don't think that there is a retinal viability once it's over the retinal, because once you cut it up, it's nothing but a patch.
Yeah, I just don't, because there are, I think, some suggestions or discussions that, you actually, this neuronal tissue reintegrates into the retina, which I think, it's hard to imagine, but you never know. So that I was just wondering if anybody has, because many times, with these large macular holes, basically the retinal tissue is missing. So you can do many interesting techniques trying to close the hole. But the visual outcome is usually not that great. You go maybe a line better, but you don't really get good vision because there are no photoreceptors.
Yeah, people have done putting extra IOM tissues, capsules, everything. But the idea that the transplant tissues from the peripheral retina become a macular kind of architectural reoriented photoreceptors, it's difficult to understand unless there's a trophic directions that changes the cellular component. So that's part of the reason why I think it may look good to you in terms of having a patch of tissues covering the whole, but the visual potential or visual improvement shouldn't be that much different.
Because I think, actually, if I'm not mistaken, I think it's actually a clinical trial going on. Yeah, looking at this, I think, which is interesting to see, because sometimes you really don't know how the tissue reintegrates, but it would be interesting to see.
Of course, I think that there is ground for these techniques, especially in cases with high myopic cases, with myopic macular holes, that in order to prevent a retinal detachment, not to restore the functional outcome.
Yeah, exactly. And those are difficult to fix, but I think many of those you can fix them maybe with ILM flap and relieving the traction. So, but I agree with Ehab. I think one question is just patching. The other question is whether you're actually getting a rejuvenation of tissue and improved vision, basically a new macula, and that's, I thought was interesting.
One interesting comment was from neurosurgeons discussing this technique with them. They doubt that there will be any type of synaptogenesis that would happen between these cells or differentiation. And if this happens, they said they could do the same thing for brain transplant.
No, but especially one of the things I was thinking is if you want to do it, you don't want to diatomize the edge. You want to make sure that edge is viable if you're putting it in.
Also, the graft is harvested from a road ridge area that sees at best 20 to 100. So it's kind of, peculiar, how this, people end up with better vision.
Unless there is some trophic effect or something that we don't, again, the question is something that we don't really understand.
Yes, perhaps it will help the parafoveal vision, improving the photoreceptor layers, because one is sure the pupillar cells will never connect again with ganglion cells. That's for sure. That's a nice, tough case starter.
And going back to what you said, Thanos, if this really works, then you don't really want to go peripheral. You want to go probably perifoveal, because then you have more cones and better cells to put in there.